Welcome, future pharmacists and colleagues. I'm your professor, and as someone with over 30 years of clinical and teaching experience, I am absolutely thrilled to guide you through this high-yield explainer on pharmacovigilance. Look, whether you're a B.Pharm student, a Pharm.D candidate, or grinding away for your GPAT and NIPPER exams, this right here is foundational knowledge. We all know that before a medicine hits the market, it goes through highly controlled clinical trials. But what happens when millions of real, diverse patients actually start taking it? Well, that's exactly what we're going to master today. Let's dive in.
Okay, so here's our quick agenda for today's explainer. 1. The history of drug safety. 2. Core definitions. 3. ADR classification. 4. The PV process. 5. Global and Indian networks. And finally, number 6. The future of pharmacovigilance.
All right, Section 1. The history of drug safety.
Now, you definitely want to mark these dates down in your notes because they pop up in competitive exams all the time. Back in 1937, a liquid formulation of sulfanilamide containing a highly toxic solvent, diethylene glycol, caused over 100 deaths in the U.S. It was a massive wake-up call that forced the creation of far stricter regulations. But then, in 1961, we saw the absolutely heartbreaking thalidomide tragedy. It was prescribed for morning sickness, but it ended up causing thousands of infants to be born with phocomelia, severe limb deformities. These catastrophes literally forced the world to act, leading directly to the establishment of the WHO Program for International Drug Monitoring in 1968.
Moving right along to Section 2, Core definitions.
So here is the official WHO definition of pharmacovigilance, and let me tell you, examiners love to test your true understanding of this. The absolutely crucial takeaway here, pharmacovigilance isn't just about catching adverse reactions. Listen closely to that last phrase, any other medicine-related problems. That is a massive umbrella. We're talking medication errors, drug interactions, product quality issues, misuse, overdose, and even just a lack of therapeutic efficacy. It's a comprehensive, lifelong safety net for any given drug.
Okay, pay attention to this one, because here is a classic trap that trips up students every single semester. An adverse event, or AE, is just a timeline correlation. Basically, it's any undesirable thing that happens after a drug is given, whether the drug actually caused it or not. Could be a total coincidence. But an adverse drug reaction, an ADR, well, that implies causality. It is specifically a harmful, unintended response that happens at normal therapeutic doses. See the difference?
Now, if you're sitting in front of me in your Viva, I guarantee I'll ask you the criteria for a serious adverse event, or SAE. These are the absolute red flags, guys. Death, a life-threatening condition, hospitalization, disability, a congenital anomaly, or anything requiring significant medical intervention. If literally any of these happen, it triggers immediate, high-priority regulatory reporting all over the globe because they represent severe, immediate risks to public health.
In pharmacovigilance, finding a signal is kind of like spotting smoke in a forest. It's early information suggesting a possible new causal link between a medicine and an adverse event. Now, it doesn't mean the drug is definitively guilty yet. Actually, scratch that. It just means experts need to grab their gear and investigate immediately to see if there's an actual fire.
Let's jump into Section 3, ADR classification.
Let's completely master the Rollins and Thompson classification. Seriously, just use this simple ABC memory trick and it'll save you on your MCQs. Type A is augmented. It's predictable and dose-dependent based on the drug's pharmacology, like hypoglycemia from taking insulin. Simple, right? Type B is bizarre, totally unpredictable, not dose-dependent, and often immune-mediated. Think anaphylaxis from penicillin. And Type C is for chronic use. These are issues that emerge after long-term therapy, such as adrenal suppression from being on corticosteroids for way too long.
Continuing that alphabet trick, we have Type D for delayed. These are effects appearing after a long latency period, like drug-induced teratogenicity or cancer. Type E stands for end of use, basically your withdrawal syndromes when a medication is suddenly stopped. And finally, Type F is failure, an unexpected therapeutic failure, like antimicrobial resistance where the drug simply doesn't do its job anymore.
Section 4, the PV process. So how exactly does a single observation at a patient's bedside become a worldwide warning? Well, it's a rigorous 6-step process. First, you have detection by a healthcare professional. Then, Step 2 is reporting it via standardized forms. Step 3 is data collection, where we gather the patient's history and clinical outcomes. Step 4 is assessment, where experts sit down to evaluate causality. Step 5 is signal detection, hunting for unusual patterns across massive global databases. And finally, Step 6, risk management, where authorities step in to update drug labels or even withdraw the drug entirely to stop patient harm.
Section 5, Global and Indian Networks. And hey, really quick, if you're enjoying this masterclass and it's helping you prep, make sure to like, comment, and subscribe to PharmaEd for more pharmacy lectures, GPAT prep, and semester notes. All right, back to the networks.
For those of us practicing right here in India, this is your home turf. Established back in 2010, the Pharmacovigilance Programme of India, or PvPI, is our national safety net. It operates through a massive nationwide network of adverse drug reaction monitoring centers, mostly in medical colleges and hospitals. Your reports go straight to the Indian Pharmacopoeia Commission. They analyze the findings and then feed this vital safety data directly into the WHO's global network. It's a fantastic system.
Zooming out globally, the WHO coordinates the overarching network, while the Uppsala Monitoring Center, or UMC in Sweden, manages VigiBase. And VigiBase is literally the absolute largest ADR repository in the world. Meanwhile, the FDA runs the FAERS database in the US, and the EMA maintains UDRA Vigilance in Europe. This deeply interconnected web ensures that if a rare side effect is discovered in just one country, it instantly alerts the entire world.
Section 6. The future of PV. As future medication experts and clinical pharmacists, you are the frontline defense on the hospital floor, period. Your role goes way, way beyond just dispensing. You have to actively detect ADRs, counsel patients on safe usage, conduct really meticulous medication reviews to prevent errors, and, importantly, sit on hospital pharmacovigilance committees to enforce rational prescribing practices.
But look, I have to be honest with you, you're stepping into a system with some pretty huge hurdles. Severe underreporting and half-filled-out forms plague our hospitals every single day, mostly just due to a lack of awareness. And proving actual causality, that's incredibly tough. Combine that with the sheer complexity of polypharmacy in elderly patients, plus this massive, rapid surge in new biological therapies and complex herbal medicines, yeah, safety monitoring is a monumental challenge right now. To overcome those challenges, your generation is going to wield some truly incredible tools. The future of pharmacovigilance is undeniably digital. We are rapidly moving toward AI and machine learning for instantaneous signal detection. By mining big data from electronic health records, pushing mobile reporting apps, and fully leveraging pharmacogenomics, we're not just going to react to adverse events anymore. No, we're going to predict patient-specific risks and intercept them earlier than ever before.
So, I want to leave you all with this final, provocative thought. No medicine is entirely risk-free. None of them. The real question is, how will you use this foundational knowledge in your daily practice? Will you be the sharp clinician who spots that faint signal and actually saves a life? Because a strong culture of safety, it starts with you. Keep monitoring. Keep reporting. If this explainer helped you prep, share it with your cohort, and let's keep making healthcare safer for everyone. Class dismissed.